been getting these questions time and again, and strangely, none of our textbooks have anything about the cups. So I thought I'll also be learning along with you all about the cups, because the constant question is from the young girls, especially girls at 12, 13 coming up with the cups. There's a big fear of the virginity being lost. Actually, we all need to understand that there's a hymen which is already having an opening there. The menstrual blood coming out means there's a vivid opening in the hymen. So we just don't need to worry about the hymen being broken. It's not a tough door which is there. It's basically remnants of a thin membrane-like thing. It's almost like a very slender curtain, and it is already a hole there. And by inserting a cup, really, I don't think it should cause any problems. But it's important that the girl who wants to insert a cup puts a cup, not the mom who wants the girl to insert a cup. So that's the key thing. If she's comfortable with it, I think it's fine. It's absolutely fine. And I think the cup is the way forward for containing menstrual blood. I think we should all revisit. Goodbye to tampons and pads, especially a strict no. As mentioned by Ira, pads is a big problem, especially in women who have heavy periods. Heavy periods containing menstrual blood by pads can be very challenging, and then you need to use several pads, and then the soreness with the pad is a big deal. And then when you wear a snugly fitting panty, the humidity which works there can cause more problems, and then there are more issues. So I think the way forward is the cup, and we all need to probably, promote this in a big way. So we are talking about menstrual concerns at different age groups. It can be puberty, it can be in the reproductive years, and it can be in the postmenopausal age group as well. Now, when we are talking about normal menstruation, we need to understand that normal menstruation starts roughly around the age of 10, and then women tend to have periods till the age of 52. During the pandemic, we did see a sudden surge of early periods. We saw a whole lot of women bringing their daughters at 8.5, 9 with early periods. So, what happened during the pandemic? Young girls had no peers to interact with. All the time they were with the screens and the monitors with online classes. No physical activity because they're not supposed to, interact with anybody. And eating was bizarre because nothing else to do, and eating and watching monitors. I think this caused a big impact on the brain. We all need to understand that the brain gives signals to the ovary to manufacture the eggs. I think somewhere with the pandemic, we did notice a remarkable increase in the onset of menarche in terms of the age. I'm sure we're going to come up with more data on this, and we will probably have ideas as to what really caused it. But I do feel it's inactivity, lack of interaction with the peer group. Probably all of this contributed to an early menarche. So most women, fortunately, tend to hit menopause by 52. So whenever women at 48, 49 come up to us with heavy menstrual bleeding, we try to dissuade them and say, do not do a hysterectomy. Because many a times you can try to, get over the problem by doing simple things, by hormonal treatment, or by inserting a device, which I'm going to probably talk to you as we go along. So this is about normal menses. It's important to understand the cyclicity can vary from girl to girl or woman to woman. So a lady can have a period every 25 days and a lady can have a period every 31 days as well, and both of them are normal. As long as the lady is able to predict when her next period is going to come, the cyclicity is pretty much normal. So how does one manage menstrual flow? Like we mentioned, we talked lots about the menstrual cup. Pads, I don't think we need to talk at all. Tampons have also been popular, but I think with the advent of the cup, tampons have taken the backstage. So when is menses considered heavy? Now heavy menses is a very subjective feeling. I have some young girls who come up and say, I'm bleeding like a tap. But then, it's subjective. So how does one assess whether the bleeding is heavy or not? If they have to change a pad every hour, or if there are huge clots coming up with each flow, or if they have to change pads several in a day, these are probably small markers to check whether there's any heavy menstrual bleeding. Now with the cup, it's much more easier. because you can measure the blood loss and it becomes far more easier, and there's an objective way of assessing low hemoglobin or assessing the blood loss. So we need to understand with normal periods, nobody drops their hemoglobin. The nature has designed menses in such a way that with every menstrual flow, you lose just about 80 ml. So you're not going to drop your hemoglobin with each period. If a girl or a woman drops her hemoglobin in over a period of, before the period and 1 week after the period, there's a drop of more than 1 gram, then probably this bleeding is supposed to be heavy. So what are the causes of heavy menstrual bleeding? Hormonal causes are probably one of the most common causes for heavy menstrual bleeding. So here what happens, we need to know that ladies have two hormones, estrogen and progesterone. In the first 14 days, we have the estrogen acting on the lining, and then we have the egg release happening on the 14th day, which is the ovulation, followed by the progesterone, which is manufactured by the ovary. And what progesterone does is it makes the lining very compact and it helps in controlling bleeding. So if at all a lady is having a hormone problem, the problem is a deficiency of estrogen, a deficiency of progesterone, because there's plenty of estrogen in the body. So what's exactly happening? They're not releasing an egg. Progesterone manufacturing happens only after the release of an egg. So what typically happens with heavy menstrual bleeding is there is no egg release, and thereby there's only estrogen, which is constantly bombarding on the lining of the uterus, what we call the endometrium, and it becomes thick and thick and thick, so much so that in some women we can see endometrium as thick as a thick layer of, as a kerchief, shoved inside the uterine cavity. So thick endometrium is the cause, basically due to excess estrogen and unopposed estrogen on the uterus. So there's no progesterone acting, there's only estrogen acting, and that's the cause for the heavy menstrual bleeding. So the common other causes are fibroids. We see fibroids in 1 in 5 women. I have some women who come up to me and say, Doctor, my scan says I have a fibroid and I want my uterus to be removed. No, you don't need to remove your uterus just because you're harboring a fibroid. Because 20% of Indian population have fibroids, while 50% of African women have fibroids. So if we get to remove everybody's uterus with no symptoms, it makes no sense. So we don't need to remove everybody's uterus harboring a fibroid. So we remove uterus only when fibroids pose a problem. And which are the fibroids which pose a problem? The fibroids which are just underneath the lining of the uterus, what we call submucous fibroids. These are the nasty fibroids which do not relate to any kind of hormonal therapy, and then women may have to be subjected to surgery. The other bunch of fibroids are the fibroids which jut into the uterine cavity like a chandelier in the room, and those are also the ones which can pose a problem. So if we can see here, so this is a polyp, a fibroid-like polyp which is there. This is a nasty one. This is a submucous fibroid. These are fibroids which are increasing the surface area out there, and they cause heavy menstrual bleeding. The other causes of heavy menstrual bleeding are polyps. Polyps are small finger-like growths. They are not tumors. They are just endometrial lining which is thickened up and coming up as a finger-like growth, while fibroids are tumors. And thankfully, these tumors are benign. They are not cancerous. In 99.9% of them, they are benign. Only in about 0.1 to 0.01% we see that fibroids are malignant. So have you any idea which of the ones are malignant without doing any tests? Unfortunately, there are no markers to identify which fibroids are malignant. Because 99.9% of fibroids are benign, we try to brush everybody's fear aside and say the chances of malignancy is less. If we had an ovarian tumor, and to identify whether ovarian tumor is malignant or not, we have blood tests. But we do not have tumor markers for fibroids. So that's the sad part of fibroids. So how do we follow up women with fibroids? We ask them to do serial scans. We see whether there's an exponential growth. And we also highlight the symptoms of fibroid which we need to be reported, like heavy menstrual bleeding and probably other concerns like pressure symptoms. So women with on blood thinners, because I work in a multi-speciality hospital, I have a lot of women who are on blood thinner injections because of mechanical cardiac valves. So these women tend to have very heavy menstrual bleeding, and such women are a big chunk in our practice, especially in a place like Fortis. So how do we treat heavy menstrual bleeding? Like I mentioned, the commonest cause of heavy menstrual bleeding is hormonal. So it's simple, we give hormones. What hormones? Now you know it's progesterone. So we give progesterone. So what do progesterones do? They make the lining very compact and they prevent heavy menstrual bleeding from happening. But these progesterones work only while you give them progesterones. Once you stop progesterones, the bleeding starts all over again. So it's going to be a cyclical course of progesterones which you need to take every month. So that becomes a little cumbersome because you're taking a tablet every month from the 5th day to the 25th day of the period. The other problem when women take progesterones, it doesn't act as a contraceptive. So if there's an egg release happening, you can accidentally get pregnant and you won't even realize because progesterones actually help pregnancy to happen. So the drawback of progesterone therapy is that you need to partake the tablets every single day from 5th day to 25th day, and then it doesn't act as a contraceptive. So the innovation is about Mirena. So I'm sure people here would have heard about Mirena. So Mirena is a progesterone releasing intrauterine device. So instead of taking progesterones orally, this Mirena, which is inserted, releases progesterone gradually over a period of time, and heavy menstrual flow is managed. So once inserted, the Mirena remains inside the body for about 5 years. And in women, if we insert it after the age of 45, we allow the Mirena to be remaining there even up to 7 years because it acts for heavy menstrual bleeding for 7 years, while it acts as a contraceptive for 5 years. So the advantage of Mirena is it doubles up as a contraceptive as well, and hence Mirena is very popular in women with heavy menstrual bleeding, also desirous of contraception. So whenever there's a fibroid, like a submucous fibroid, Mirena doesn't help. One, the cavity is distorted because the fibroid is jutting into the cavity. Thereby, Mirena doesn't snugly fit in, and then there's a fall off of the Mirena, or the Mirena doesn't suit at all. Polyps, when they are there, again a problem. The polyps need to be removed, and only then we can consider inserting a Mirena. So, if you have a submucous fibroid, or if you have polyps which are jutting into the uterine cavity, then we need to do a surgery and get that thing sorted and then address the problem if needed. Removal of the uterus is the last resort. So most often when women come up to me and say, remove my uterus, most of them do not need it. There are very few actually who really need it. And you do a hysterectomy when a person really deserves it and then they feel, it's worth doing it. But if you just jump on a person and do a uterus just because there's an incidental fibroid picked up on the scan, that's wrong practice. So treatment depends on the age. Young girls who have attained menarche, what happens typically? Ovulation is erratic because the brain is just giving signals to the ovary, and thereby there can be phases when they release it, when they don't release it, and so the periods can be erratic, and by and large, eventually things get sorted. So we tell young girls who come up to us, wait for a year or two, and things will fall back in place. But we tell their moms that ensure that they have an iron-rich diet. They're doing is enough physical activity, not eating junk, because all of these can add up to weight. And once they put on weight, they can have something called polycystic ovarian syndrome, where the eggs don't get released, and then it becomes a vicious cycle. So young girls need to understand to remain active, eat healthy, and then just keep us posted on any unusual or bizarre symptoms. And as I mentioned, when you have a fibroid polyp or it needs to be removed, else we can manage with hormones. Women at the brink of menopause are the ones who do not need a surgery. You just need to tell them that the menopause is round the corner and most people will, sail through menopause smoothly. And some of them may need a Mirena insertion to tide over the crisis period. So now we were talking about the treatment for different age groups. So what does Mirena do? It releases a hormone called progesterone. And so when it is inserted, about 95% of them have less bleeding, 35% of them have no bleeding at all, while 1 in 20, the Mirena can fall off. So the IUCD is not accepted by the uterus and it just falls off. Then you may need to think of other modalities of treatment. So hysterectomy, when do we do it? It's the last resort. When none of these work, this is the only time we do a hysterectomy. In fact, we make it a point to ensure that the woman earns an indication for a hysterectomy. Because if we follow all these protocols and we do a hysterectomy, we are justified. Because hysterectomy is a major surgery in terms of getting one of the organs removed. And whenever we remove the uterus in the age group less than 52, we tend to keep the ovaries behind because ovaries is the seat of manufacturing of hormones, and that is important for overall women's health in terms of heart, in terms of brain, etc. But when we leave the ovaries behind, the problems are sometimes women can hit early menopause because the ovary gets a little depressed that the neighbor has gone, and also the blood supply to the ovaries can change a little bit, and hence they may hit premature menopause and they can get into trouble. But most often we leave both the ovaries behind, and it continues to manufacture hormones. Some of them who have their ovaries left behind can develop some small water bubbles in the ovary, and we may need to do further surgeries. But that's a trade-off we do because ovaries are needed for young women. So we leave it behind as much as possible. So whenever we do any surgery, we need to know there's a risk of bleeding, there's a risk of infection, there's a risk of injury to neighboring organs, and hence, as I mentioned, we do a surgery only and only if it's absolutely indicated. Most people recover pretty much well within 2 weeks. Usually, most people bounce back to normal. Yes, it depends on the route of surgery. Now, when we do a surgery by the abdominal method, that is what we call a laparotomy, then there's a big cut, then the recovery can be a little longer because there's more pain, more distress, more tissue handling, so they take a longer time. Thankfully, now most of our surgeries are by minimal access techniques. There are very far and few surgeries where we remember where we have done an open surgery, but mostly we do a laparoscopy or a robotic surgery. At this point of time, we are doing plenty of laparoscopic surgeries and the results are phenomenal. I have had women who have come down from Africa, done the surgery on a Friday, and gone to see Mysore sightseeing on Monday. So this has happened, and it all depends on the willingness to recover. So it's important if you're fit, if you have decided I want to get my uterus knocked off and you're mentally prepared and then you do very well, your recovery is amazing. So if minimal access is the way forward, just like I mentioned, menstrual cups are the way forward, minimal access as far as possible, we resort to that because the results are very amazing. The tissue handling is very little. There are some very complex cases where we have still managed, by laparoscopy. We work as a team. Independently, laparoscopy is impossible. I can do an open surgery almost alone with a nurse, but for laparoscopy, we need a big team. But that team helps in delivering the goods. So, what's the aftercare for a hysterectomized patient? So, once hysterectomy done, we recommend no sexual intercourse for 3 months because the vaginal vault is sutured and it's a sensitive zone and bleeding can happen. After 3 months, they can indulge in intercourse, and if the ovaries are retained, there's not much problem with libido or pain. Most people feel fairly comfortable. No lifting very heavy weights is another important thing because the vault, which is the empty area where the uterus has been removed, can have a problem because the vault can come out. The empty area will get occupied by the intestines and the intestines can sag down. So this is another important thing, and very important not to be constipated. It's good to have good fiber and not to strain while passing motion. Hydration is a very important component because when we do a hysterectomy, we put a urinary catheter and that can cause urine infection. So it's important that women have enough fluids and hydrate themselves well and are not constipated. So after hysterectomy, usually no follow-up is needed unless they have some severe pain, etc. We may need to see whether the ovaries are developing some cysts, etc. So the other thing I needed to talk is about painful periods. So normally periods can be a little painful. Most people tend to have a little bit of back pain, lower abdominal cramps, thigh cramps, and people get along doing their usual physical activity, usual routine work. But painful periods which incapacitates people from doing their day-to-day work is what we are talking about. So the common reasons for painful periods is congestion, where there is a little bit of water collection in each of the cells. The cells get bloated with water. There is edema, what we call, and thereby, they can have severe pain. The other common conditions which are causing severe pain is adenomyosis and endometriosis. Now, the uterine lining is what which is shed during periods. In some people, this uterine lining goes and lodges in the wrong areas. So they go and lodge in the muscle layer, they go and lodge on the ovaries, and that is what we call adenomyosis. So when it is lodged on the uterus in different parts, because the lining is supposed to be here, while in adenomyosis, the glands are getting trapped here. And what happens is when she gets her period, she bleeds from here, which has a vent out, while the bleeding which happens here has no vent. So it keeps on accumulating and a woman can have severe pain. In fact, I pity women with adenomyosis because most of them, their husbands, their in-laws, their friends kind of ridicule them. Periods is such a common event. Why do you hype it so much? Unfortunately, women with adenomyosis can really go through very severe pain, almost similar to labor pains. So I have always seen that women who come up with severe pain usually have adenomyosis. Adenomyosis is glands trapped here. So how do you treat there? You can't sit and remove these glands. They are all microscopic glands. So how do we treat? I'll come to that. And this is an adenomyoma. It looks like a fibroid, but it's not a fibroid. It's a concentrated gland collection in the middle of the muscle of the uterus. Again, every periods they bleed inside as well, and there's no vent, and thereby they tend to have severe pain. So these adenomyomas are sometimes very resistant to hormonal therapy, and then we may have to resort to surgery. And removal of adenomyomas, unfortunately, is not as easy as removal of a fibroid. Fibroid has got a capsule, it's easy to reach there and take it. Adenomyoma is merged with the uterus, it's very challenging to remove an adenomyoma. So, treatment, again, painkillers. Dynogest is innovation for adenomyosis. It's been a great drug for endometriosis. When the lining is lodged on the ovary, we call it endometriosis. When the lining is submerged within the layers of the uterus, we call it adenomyosis. Both of them are almost the same problem in different ways. So when it is affecting the ovary, Dynogest acts very well because it prevents heavy bleeding and thereby bleeding doesn't happen in the ovary and the pain eventually dwindles. Mirena is another way to overcome pain during periods because what Mirena does is it reduces the flow and thereby the bleeding inside those ectopic sites reduce and people feel far more comfortable. Surgery needs to be done as a last resort. So to sum up, I thank you all for coming on a Sunday. I think Sundays are really, really precious and I do really appreciate that all of you have come. My colleagues who have been celebrating Ramzan, thank you so much for coming. And my colleagues who have celebrated Ugadi, thanks a lot for coming after a busy festival. So thank you very much. And I fail in my duty if I don't thank my secretary, Charita, who's been up behind and making all the telephone calls. Otherwise, this would have been impossible. And Savya and Priya for having organized. They initiated it, they triggered me to do it. Thank you so very much. And I thank Asan Cups as well for having come and enlightened me. Thanks all for coming. I think it really made my day. Thanks, and I wish you all a happy Sunday. Please do join us for lunch.